acute fever with last time we talked about the fever with few of the acute patterns and their clinical clues such as fever with rigors, fever with anorexia, fever with weight loss, fever with lymphadenopathy, hepatomegaly, and splenomegaly. So those were the. Now today we'll talk more about additional clues, and one of those clue is swinging pyrexia. Swinging pyrexia means that the patient gets high spikes of the temperature multiple times at without any regular pattern in 24 hours. That's called as a swinging pyrexia. For example, patients get 103, 104 temperature with rigors, and there's no fixed number of the episodes in 24 hours. So multiple times high grade temperature with spiking, and the temperature is often non-localizing. This is classically an example of an acute abscess. Acute abscess causes swinging pyrexia. Similarly, any bacteremic infection, when it is well established, there's a lot of bacterial load in the blood, which has seeded the liver and caused small abscesses there. They also causes swinging pyrexia. Okay, endocarditis is another example. So any infection, when it gets well established, can cause swinging pyrexia, especially acute bacteremic and acute abscess. Sometimes the abscesses has a location which is not clinically so evident. For example, patient has a subphrenic collection or subhepatic collection. In these locations, they are often missed because they are deep seated, and similarly paraspinal collections. For example, in the paraspinal area of the thorax or paraspinal area of the abdomen, okay, or deep pelvic abscesses, for example, prostate abscess. So these abscesses which are difficult to find, difficult to detect, and sometimes there are subtle clues which can help. For example, if there's a subphrenic collection, the only clue may be that the right or left hemidiaphragm is elevated more than usual. So that may be the only clue. Okay, or the patient has a reactionary pleural effusion on that side. Okay, that's for the subphrenic collection. Paraspinal collection may cause neuropathic pain by irritating the intercostal nerves which are coming out of the spine, or they can just present with the back pain. Similarly, abscesses in the head and neck area, there are so many fossas in the head and neck area, like pterygopalatine fossa and other fossas where the hidden abscesses can be easily missed. So in these cases, the first choice is to do a CT with the contrast that may detect many of the hidden abscesses. But CT has a limitation. Wherever there's a tissue crowding, for example, in the paraspinal area or in the head and neck area where there's a lot of tissue crowding, CT get confused. So in those cases, if you want to detect the hidden abscesses in those areas, either you do a MRI with the contrast or you do a radionuclide labeled white cell scan. So they will tell you the site of the infection, and then we can aspirate that. So that is about the hidden abscesses. Okay, some of the abscesses, such as prostatic abscess, may be easily detected if we do a rectal examination, and if there's a prostatic tenderness, so that can be easily detected. Same goes with the pelvic abscesses. Okay, so careful examination and with mindful of the thing that the CT contrast can miss abscesses in the overcrowded areas with a lot of tissue crowding, especially the pelvis or the paraspinal area or the head and neck area. CT can be normal in these cases, even if there are abscesses. So we have to do some more investigations, such as MRI with the contrast, or such as the white cell scan, which are radio labeled. Okay. The next thing which I want to elaborate a bit more is a fever with lymphadenopathy. There were few questions which were asked to me in person through the WhatsApp message, so I would elaborate that. Remember, confusing lymphadenopathy of a lymphoma versus systemic viremia is something which is important to keep in mind. Systemic viremia usually causes rapid onset of generalized lymphadenopathy involving many sites. Okay, and usually the lymph node size does not go beyond 2-3 centimeter. Okay, whereas lymphoma often causes focal lymphadenopathy to start with. So there's always one or two index lymph node from where the lymphoma is starting, and then it can spread to the other lymph nodes. So there are lymph nodes which are usually get bigger and bigger and bigger, And so whenever the lymph nodes are like 3 centimeter or beyond that, they are more likely to be a lymphoproliferative disorder than rather than HIV or EBV or CMV. Okay, so and then if the lymphadenopathy is generalized right from the beginning within a week or 2 weeks, this is very unlikely to be lymphoma pattern. It can happen, but it's less likely. But it's more likely to be a reactive lymph nodes secondary to a systemic viremic response. Okay, so HIV seroconversion or cytomegalovirus or Epstein-Barr virus or toxoplasma virus. But if the lymphadenopathy is focal, such as mediastinal lymphadenopathy or just paraaortic lymphadenopathy, or cervical lymphadenopathy without involving the other sites, this is less likely to be a response of the systemic viremic response. Okay, this is more likely to be a lymphomatous response. So you need to be a bit more uh, proactive to exclude lymphoma in those cases. Okay, and similarly, TB can cause lymphadenopathy, but tuberculosis lymph nodes will cause TB as such will cause focal lymphadenopathy. It's rare for the TB to cause a systemic generalized lymphadenopathy involving many areas, such as involving cervical, mediastinal, para-aortic, and inguinal at the same time. It's less common pattern. So in those cases, TB, whenever it causes lymphadenopathy, it basically causes necrosis and fibrosis together. So lymph nodes has fluid in them. Lymphoma and viral infection, they are extremely rare to cause necrosis of the lymph node, which is grossly visible. They may cause a microscopic necrosis, okay, but necrosis to the point that start creating fluid in the lymph node or an abscess or picture of sinus, or that is very uncommon with the lymphoma and viremias. That is more common with the TB and fungal infections. Okay, another another important point is
आसिफ
because
भाई
the
ये
TB,
काइंडली पॉइंट रिपीट कर दीजिएगा। हाँ जी,
lymphoma and
ये
viral
पॉइंट काइंडली
infections.
रिपीट कर दीजिएगा जरा, वॉइस।
Lymphoma and viral infection, they are extremely rare to cause lymph node necrosis. They do not cause necrosis in the lymph nodes. For me, they don't cause. They are extremely rare to cause lymph node necrosis. So presence of the fluid in the lymph node, sinus tract formation or fluctuation is extremely rare, and it goes against lymphoma and uh, viral infections. Okay. However, TB and fungal infection, when they cause lymphadenopathy, they cause significant necrosis, which is grossly macroscopically visible. So they may cause pus formation or sinus tract formation. Similarly, lymphoma and viremia, they are less likely to cause fibrosis in the lymph node. So presence of a significant amount of fibrosis, which causes adhesion of the lymph nodes together when the lymph nodes become matted, either with each other or with the adjacent structures such as overlying skin or the trachea or the adjacent structures, that usually goes in favor of infections such as TB and fungal infections. Okay. So these are the few points about the lymphadenopathy. We will have a separate lecture on the lymphadenopathy. Okay. Then I want to highlight something about the chronic malaria. We discussed about the pattern of the acute malaria in the last lecture, that acute malaria causes periodic fever which comes at a regular interval with rigors, and fever usually comes once the malarial cycle is complete in 24 or 48 hours, and there's early splenomegaly. Okay, and it's a non-localizing infection. That's a classic acute malarial fever. Okay, chronic malaria, what happens in the chronic malaria is infection transitions from the acute phase to the chronic phase. Now it means that infection is more becoming like a monocytic and macrophage infection rather than acute infections. Okay, secondly, when the malaria becomes chronic, even if the parasite is one, but there are multiple life cycles of the malarial parasite which are running parallel to running at different time phases. So there are multiple cycles running at the same time. Okay, so fever almost becomes continuous rather than episodic, periodic. It loses the periodicity. It becomes a continuous fever. But because it's a chronic infection, so fever usually is not very high grade, and it may not have rigors. Okay, so chronic malaria is not always periodic, is more like a chronic fever. It's not always with the rigors, it's a low grade fever. And okay, and because with the passage of the time, the more you irritate, more you damage the red blood cells, the spleen reacts more and more, and splenomegaly becomes uh, huge in size. So, significant splenomegaly, which is uh, grossly enlarged, ongoing continuous fever without any periodicity, and rigors. This is the pattern which when the malaria transitions from acute to the chronic malaria. So in chronic malaria patients, the clues will be low to moderate grade fever without rigors and a significant splenomegaly. Okay. The other causes of the significant splenomegaly is a leishmaniasis, calazar, but that becomes with the different clinical clues, skin discoloration, skin ulcers, and splenomegaly. Okay, so this is about the chronic malaria. So remember, chronic malaria is different from the acute malaria. We don't need to confuse the two patterns. Okay, so absence of rigors, absence of periodicity doesn't exclude chronic malaria. I think that point should be clear now. Now, coming to the point of the other chronic infections, I will briefly touch it because each one of them needs separate one or two lectures. So, okay, many of you are aware of the TB, so I won't spend much time on the TB in this lecture, but I will spend on a few other things which can mimic like TB. One of those infection is a nocardia. Okay, nocardia infection is somewhat resembling to the TB because most of both of them, TB and nocardia, they commonly involve the lungs. Lungs is the common site, but there are two, three significant differences between the two. TB infection, when it involves the lungs, it usually respects the tissue planes. You will never see the TB extending from the lung to the overlying rib cage, or to the intercostal muscles, or to the chest wall. It will never happen. You can see any patient of the TB. So TB usually respect the tissue plane. It can go from the lung to the pleura, but it's not common that pleural TB is going to invade the rib cage. So if any infection is invading the rib cage, that is nocardia. So nocardia doesn't respect the tissue planes. It crosses from one plane to the other plane to the other plane in an adjacent fashion, in a contiguous fashion. So it starts from the lung, it can erode through the pleura, it can erode through the intercostal ribs and the muscles and come to the chest wall. So sinus formation is very common in the nocardia, which is very uncommon in the TB, number one. Number two, nocardia is a necrotizing infection with minimal fibrosis. Tuberculosis infection causes necrosis, but that is a caseous necrosis. So that is not, I mean, huge, but at the same time, it also causes fibrosis as well. So TB causes fibrosis more than necrosis. Okay, nocardia is either causes no fibrosis or minimal fibrosis with lot of necrosis. So there's a lot of pus formation, but there's no significant proportionate fibrosis in the lungs. So there's a chronic infection. There's a lot of liquid in the pleura or in the lungs, but there's no significant fibrosis. Or the infection is crossing the tissue planes without respecting them. This pattern is either with the malignancies. Malignancies doesn't respect the tissue planes, and they cross from the lung to the overlying ribs or the intercostal muscles or wherever. And this pattern is also there with the nocardia. So in those cases where the infection doesn't respect the tissue planes, or there's a lot of pus and liquid, but minimal fibrosis or no fibrosis, you should keep nocardia high on the list as compared to the TB. Because in our part of the world, tuberculosis is very common and it can fit any pattern, but this is very important to keep in mind so that you're not confusing with it. Fungal infections, they are also chronic. They're usually happening in the background of severe immunocompromised state. Patient is usually immunocompromised, has like a cancer, has a metastatic cancer. Patient is on cancer chemotherapy. Patient has neutropenia. Patient has patient is on rheumatological drugs, for example, cyclophosphamide or biologics. Okay, so and patient has autoimmune diseases or immu- uh, autoimmune sorry, acquired immunodeficiency syndrome, AIDS syndrome, or HIV. So these are the patients who usually have a background for a fungal infection to establish. Okay. Now there are two few important things which you need to understand because I'm highlighting their important points which are not mentioned clearly in the books. Number one, often you can find a fungus in the sputum or in the urine. So the question becomes, should we treat it or not? Okay. So one of the clue is if you find a fungus in the blood, or fungus in any tissue sample. For example, fungus in the blood, or fungus in a biopsy sample, or a fungus in the CSF. This is a never a contamination. This is a proper fungal infection. So finding a fungal in a tissue specimen like biopsy, like CSF, like blood is always significant, is never contaminant. It has to be treated. Finding a fungus in sputum, which is a, because the lungs are in communication with the outside world. So many a time some of the fungi such as aspergillosis or such as candidiasis, they can actually they can be colonizer. So in those cases, how to decide that this fungus is causing the problem? This is important. Okay. Now, as I said, if you find a fungus, any fungus, Candida, aspergillosis, or anything in a tissue biopsy, for example, we did a lung biopsy and we find a fungus. We took a blood culture and we found a fungus. We did a lumbar puncture and we found a fungus. We did a liver biopsy or kidney biopsy or skin biopsy and there's a fungus in the biopsy specimen. That has to be treated. But if that is not the case, if you find a fungus in the urine or fungus in the sputum, in those cases, remember the important clue is that we need to fulfill these following conditions. Number one is the growth is heavy uh, on the culture. Okay, so you are finding a heavy growth. Number two, you don't have any other explanation to explain those symptoms. Okay, and number three, it is positive in multiple samples. So if it's positive in the multiple samples, it's positive in heavy amount, growth is heavy, and there's no other explanation. And if it's candida in the urine or candida in the sputum, go for it and treat it in the appropriate clinical background, such as patient is immunocompromised, patient has a respiratory lung problem, and we're growing candida in the sputum in heavy growth in multiple samples, and there's no other infection detected. Yes, this candida need to be treated. If these are not fulfilled, patient is not immunocompromised, the lung infection can be explained by other coexisting pathologies, and it's not positive in multiple samples, you can just discard it. Okay, the same principle applies to the urine. Okay, fungal infections are rare to cause organ invasion in immunocompetent patient, but sometimes they can, especially the cryptococcus one can cause fungal infection in immunocompetent people very commonly. Okay, it can cause cryptococcal pneumonia or it can cause cryptococcal meningitis as well, right? Because it's very prevalent, especially this is prevalent in the trees and in the soil. Eucalyptus tree, which is very common, is one of the natural habitat for the cryptococcus. So it can be people who deals with the trees, woodcutters, and those who deal with the forest are very high risk of getting cryptococcal infection, even if they are immunocompetent. So keep in mind, immunocompetent people can also have those fungal infections. Okay. Now, next thing which I want to touch is opportunistic infections. I'll come to the TB, but these are more important things. But everybody will teach you tuberculosis, but these things I thought is very important. Being a clinician, you should know these things. Opportunistic infections are the one which happen in the immunocompromised patient. They are rare. They rarely happen in the immunocompetent. Just like fungal infection is one of the opportunistic infection. Few other infections are the chronic viruses, such as cytomegalovirus infecting the body organs, cytomegalovirus encephalitis, CMV retinitis, CMV chorioretinitis, CMV pneumonitis, CMV hepatitis, CMV nephritis, or CMV colitis. These are the infections which you would rarely see in any normal immunocompetent persons. In a normal immunocompetent person, CMV infection is either asymptomatic or it just causes uh, acute illness with seroconversion, lymphadenopathy, and then it goes away in a dormant phase. And whenever the person is immunocompromised, it reactivates and causes severe organ infections. Okay. Similarly, PJP pneumonia, PJP pneumonitis is another infection which we need to keep in mind if the patient is immunocompromised, or such as transplant patients and immunocompromised patients. Okay. Now, before I move on to the malignancy and the other causes of fever, let's have a little talk about the TB as well. Okay. Now, TB is so common. When I was in med school, we were taught that you can fit TB in every patient in every case. That's not true actually. Okay, because that's not the case. There are many other infections which can mimic like TB, and we often miss them and we often treat them as a TB. So in your practice, it's very difficult to say this is not TB. Okay, remember every disease has a boundary wall. There are few things which you can't explain in tuberculosis, but there are few things which are very specific for TB, which bring the tuberculosis very higher up. Okay, I often teach the concept of feature versus symptom. Feature is a symptom or a sign or a finding which is essential for to make a diagnosis of a disease. If that is absent, it is very unlikely for that disease to be present. Okay. To give you an example, itching is a feature of a primary biliary cirrhosis. So it's very unlikely to have a PBC without itching in advanced phase. Okay. Similarly, weight loss weight loss is a feature of tuberculosis with very few exceptions. The only exception to this rule is TB sitting in an area which are less vascular. For example, paraspinal tuberculosis can present without weight loss, without much systemic findings, but most of the other organs tuberculosis almost always causes weight loss. Okay, so it's very unlikely for a patient to have a significant tuberculosis, active tuberculosis with normal weight. So weight loss is a feature of tuberculosis except paraspinal tuberculosis. Okay. The second important point which I want to make sure highlight is TB causes necrosis, but it doesn't produce free liquid. It causes caseous necrosis. So there's a thick fluid, thick cheesy material. Okay. So it's less likely for a TB to produce clear fluid. Okay. It most likely produces thick viscous fluids. Okay. So, and TB causes fibrosis more than necrosis. So presence of the fibrosis helps you to differentiate as we talk about in the nocardia. Next thing is TB in the spine, which I said usually may not give you the similar symptom, is easily missed. Okay. Now, whenever we look at the paraspinal infections, spinal infections, okay, there are two areas. One, there's a vertebral bodies, and then there are discs. Okay. Malignancies, there are two common differential diagnoses involving the spine. One is infection, and other is a malignancy. Okay. Now, malignancy never involved the intervertebral discs because malignancy intervertebral disc is avascular. Intervertebral disc doesn't have any blood supply. Why the malignancy would go there when there's no nutrition? There's even the metastatic disease doesn't go there, but the TB tries to escape the blood immune system. Infection tries to escape the immune system. So infection when they involve the spine, they almost always involve the discs as well. Okay, so involving disc in a if the disc is involved, this is not malignancy. If the disc is spared, this is not infection. So spinal infection, when you're looking at the spine, look at the disc and the vertebral bodies. Okay, if the
आसिफ भाई
discs
इस
are
पॉइंट को
spared.
काइंडली रिपीट कर दीजिएगा। आज ये वॉइस इंटरप्शन दरम्यान में काफी आ गई थी, बहुत इंपॉर्टेंट पॉइंट है, इसको रिपीट कर दीजिएगा।
So we're talking about the paraspinal infection. So in the paraspinal infection, if if the infection if the disease is involving the disc, this is not malignancy because disc is avascular, and malignancy doesn't involve the avascular areas. It doesn't go to the avascular areas. So in paraspinal infection, disc is a very important clue. So if it's a disc sparing disease, this is malignancy. If it's a disc involving disease, this is not malignancy, this is infection. So this is a point of differentiation between the spinal diseases. Is it infection or is it malignancy? Okay. So TB, when it involves the disc, spine, it always involves the discs. Okay. And secondly, the malignancy may involve multiple vertebrae, but all those areas will have an intact discs. Okay. Though that is in the lungs, important clue which you need to understand in TB or any infection is you should mark these words and write it down somewhere in your uh, notebook or on the walls of your room, that in the lungs, if if a lung involvement is bilateral and symmetrical, okay, if a lung involvement is bilateral and symmetrical, okay, this is not infection, this is not TB. The only exception to this rule is a miliary tuberculosis. Okay, miliary tuberculosis involve both the lungs and all lung areas. That's the only exception. Otherwise, infections and malignancies, they are always asymmetrical when it comes to the lungs. If you are finding a disease which is involving both the lungs symmetrically, this is more likely a systemic response to an autoimmune disease or a dust related disease. This is not going to a TB. TB and infections and malignancies, they are almost always asymmetrical. Either they are involving one lung, or even if the disease is bilateral, they are not symmetrical. Okay, for example, one lung is fully involved and the other lung only has a lesion in one lobe. This is not symmetry. This is either infection or a malignancy. But if both the lungs have bilateral lower lobe involvement of almost the similar size, similar nature, this is very uncommon in the infections. I'm talking about the chronic infections and the malignancy. I'm not talking about the viral infections or atypical bacteria. Viral infections and atypical bacteria, they often cause bilateral symmetrical infection. But chronic infections are typical bacteria. So I'm repeating it. Typical bacteria, chronic infections, and malignancies. They are almost never, I'm saying almost never symmetrical. They are either involve one lung or a part of a lung, or even if they're bilateral, they are not symmetrical. So if you find a fibrosis in one lung and the other lung is normal, please, for God's sake, don't say this is interstitial lung disease. This is not interstitial lung disease if it's involving only one lung. Okay, this is infection, or this is malignancy, or this is something else. Interstitial lung diseases, occupational dust lung diseases, and fluid overload almost always involve both lungs in a symmetrical fashion. Infections, acute bacterial infections, chronic infections, all chronic infection including TB, fungus, and nocardia and all those things, and malignancy, they are almost always asymmetrical. Okay, primary malignancies. I'm not talking about the metastatic disease. Okay, so in the lungs, if you find that all the findings are on one side, or the findings are not symmetrical, think about infection, think about cancer, take autoimmune diseases out of your list, and take dust diseases out of your list. So I hope that makes some sense. Okay, rest of the things in the TB, involving the mediastinal lymph nodes without the lung involvement is is very uncommon in TB. It's more common a pattern of lymphoma. So often you will find patient has a mediastinal lymphadenopathy and lungs are not involved. TB goes on the bottom. Lymphoma and sarcoidosis comes on the top. Sarcoid grade 1 causes mediastinal lymphadenopathy without lung involvement. Lymphoma rarely involves the lungs. It involves mediastinal. So if you find a mediastinal lymphadenopathy without lung involvement, differential should be lymphoma, sarcoidosis. TB should be at the bottom. But if you find asymmetrical lung involvement, for example, right-sided lung or left-sided lung is involved with the lymphadenopathy on one side, this could be a TB. This is TB will go on the top. Okay. So mediastinal lymphadenopathy without lung involvement, this is less likely to TB. This is lymphoma, or this is sarcoidosis grade 1. Okay. Mediastinal lymphadenopathy with bilateral interstitial lung involvement in a symmetrical fashion, sarcoidosis comes on the top, TB and lymphoma goes on the bottom. Okay. Asymmetrical lung involvement, unilateral lung involvement with lymphadenopathy, this is TB or fungal infection unless proven otherwise. Okay, these are the common confusion which you guys get on the clinical ground. So that's why I'm highlighting these points more than just telling you what is a primary TB, what is a secondary TB, what's a reactivation TB. You all know those things. I don't need to repeat those things. Yes, primary TB usually starts from the lower lobes, or it can cause just a pleural effusion without causing any upper lobe involvement, and reactivation is more common in the upper lobe, as you all know, because of the more oxygen available in the upper lobes. Okay. Plus, even if it's a asymmetrical lung pathology, and you think this is infection, this could be a cancer, or this could be a infection, but don't think about autoimmune as dust diseases. Now, again, to differentiate, is it a fungus or is it TB? This is another point which we often are stuck. If the patient is immunocompetent, TB is more likely than the fungus, as you all know. Okay. Second, if there's a if there's a more upper lobe infection, okay, again TB is comes on the top, but aspergillosis also causes upper lobe infection. Okay. But aspergillosis, when it involves the lungs, is asymmetrical like TB. It can be really symmetrical, but it's mostly asymmetrical like TB. It involves upper lobes like TB. Okay. When it's invasive aspergillosis, now I'm comparing the upper lobe infection, fungal infection with the TB. Okay. Upper lobe fungal infections, especially which is aspergillosis, okay, that usually causes vascular invasion, is very common in aspergillosis as compared to tuberculosis. TB will focus mainly on the caseation, mainly on the fibrosis, but aspergillosis mainly invades the tissue, is an invasive infection. It just focus on the destruction. Okay. Rapid destruction, it causes rapid destruction, rapid vascular invasion, and that causes angio invasion or hemoptysis and bleeding more than TB causes. Okay. Right. Certainly, many a time the situation is that not everything can be differentiated based on the clinical ground, but I am trying to tell you as maximum points as can be as possible. Okay. And once the fungus aspergillosis is a invasive disease, of course you will find antibodies against the fungus. There will be a lot of aspergillus in the sputum as well. Okay. And there will be many other clues, and the CT imaging will show the lot of tissue invasion and tissue necrosis, which is the rapid necrosis, and there's not much fibrosis. Okay. Because it is a rapid necrotizing infection, so fibrosis doesn't parallel with the tissue destruction, whereas TB causes slow damage, right, and that causes fibrosis as well. Right. Few of these things are not mentioned in the books, but these are very important clinical clues which can help you in many patients. Okay. So that's why I'm highlighting. Now, coming to the fever due to the malignancies. Malignancies have multiple mechanisms to cause the fever. They can produce pyrogens. Remember, malignancy doesn't follow any rule. This is the first rule. Malignancy doesn't follow any rule. They can change one gene and they can do anything they want. Okay. All human cells have the same DNA. The only thing which matters is which genes are active. So liver cells, brain cells, kidney cells, muscle cells, bone cells, they all have the same DNA. It's just the types of the genes which are active. Types of the genes which are active in the liver, they are different from the types of the genes which are active in the brain. Otherwise, all cells have the same DNA. So cancer cells, they can activate or inactivate any gene by just causing mutation, and they can gain a function or they can lose a function. So gaining a function is not a big deal for a malignancy. They don't follow any physiology. Okay. So malignancy can produce fever by producing cytokines, by producing pyrogens. Okay. Malignancy can cause fever by necrosis in the malignancy. There's a necrosis, and that can cause. Malignancy can cause fever because of metastatic disease. Malignancy can cause fever by metastasizing to the hypothalamic area where the thermostat is, and it can alter the thermostat. Malignancy can cause fever by producing paraneoplastic response, paraneoplastic autoimmune response, because the malignant antigens, they are different from the normal body antigens. So when they get exposed to the immune system will react to them and give an autoimmune response. That's called as a paraneoplastic. Malignancy can cause fever by producing various hormones such as catecholamines, such as cortisol, such as thyroxine. Okay. And malignancy can cause fever by superadded infection. Malignancy can cause fever by the drugs we use for the malignancy, such as cancer chemotherapy. They can also have their own fever. Okay, so there are multiple mechanisms how the malignancies can cause fever. Now, when malignancy related fever, even if the patient is known to have a malignancy, patient has established diagnosis of adenocarcinoma of the lung. Okay, even when they come present with a fever, the first thing is to exclude infection. Infections are more common even in the setting of a malignancy. Infections are more common than the malignancy related fever. So the first thing is we have to exclude there's no infection. Acute infection, chronic infection, opportunistic infection, whatever infection. So the first thing when we say somebody has a malignancy related fever, we say this is a partial diagnosis of exclusion. I'm not saying complete diagnosis of exclusion. Partial diagnosis of exclusion means we have excluded at least we have excluded the infections as the cause of the fever. Once we say this patient doesn't have an infection, then we think about malignancy related fever, even if the patient has established diagnosis of malignancy. I think that point should be clear now. Now, there are few malignancies which can cause fever, okay? But before I come to that point, sometimes the malignancy is so small in size that it's not detectable by any imaging. But patient can have fever, multiple fevers, without any underlying clue why the patient is having fever, okay? Right? We done all the scans, we didn't find any malignancy, but still patient is having fever and fever and fever. It can still be a malignancy related fever because malignancy is not detectable when it's less than 1 centimeter in size. Malignancy may not be detectable if it's present in a tissue with lot of tissue crowding. Okay, malignancy may not be detectable if it's not very vascular. Okay, so there are different malignancies which may not be detectable at the beginning. We might need to reassess the patient at some intervals. Okay, there are some malignancies which are notorious to cause temperature. Of course, all of you know hematological malignancies, leukemias and lymphomas and multiple myeloma. They are notorious. Apart from the hematological malignancies, there are some solid organ malignancies which are notorious to cause fever. One of those is hepatocellular carcinoma. So, hepatocellular carcinoma can just present with fever of unknown origin, and it may not be large enough to be detected on the imaging. Even the MRI of the liver can miss a hepatoma if it's less than 1 centimeter in size. This is cutoff value for MRI. MRI almost always detects hepatoma if it's more than 1 centimeter, but it can miss if your hepatoma is less than 1 centimeter in size. Ultrasound, of course, is operator dependent, that has more limitations, that can miss even a bigger hepatoma, and the CT can also miss it. But okay, the other is a renal cell carcinoma. Okay, renal cell carcinoma, the renal cell carcinoma is also a solid organ malignancy with high likelihood of presenting just with the fever. Okay, the third, all the mesenchymal tumors, basically all the connective tissue tumors, for example sarcomas, leiomyosarcomas, rhabdomyosarcomas, okay, liposarcomas, all the mesenchymal tumors. Basically blood is mesenchymal in origin. If you look at the embryology, blood is also a mesenchymal tissue. Okay, all the mesenchymal tissue, they are highly vascular. All the mesenchymal cells, they can easily get the uh, functions of blood cells, especially the inflammatory cells. Fibroblasts can become inflammatory cells. Okay, uh, so all the mesenchymal cells, they are very, number one, they are highly vascular. Number two, they are more, that it's very easy for them to transform into uh, one of the inflammatory type of the cells. Okay, and they can produce more cytokines. So mesenchymal tumors, they are high risk for presenting with the fever rather than any other symptom. Okay, so whenever the patient present with the fever and we're thinking solid organ malignancy, look at the mesenchymal tumors. Other than the hematological malignancies, mesenchymal tumors such as sarcomas, okay, osteosarcomas, rhabdomyosarcomas, leiomyosarcomas, there are some malignancies which can cause fever in addition to these mechanisms, and they are endocrinal malignancies. Adenocarcinoma of the adrenal gland or the pituitary gland, they can produce hormones, thyroxine and cortisol, which can cause hyperthermia and which can cause fever as well. Okay. Similarly, neuroendocrine tumors, when they produce a lot of catecholamines, such as pheochromocytoma, that can also present with the fever. Carcinoid syndrome can present with because they produce a lot of neuroendocrines and a lot of cytokines as well. Okay. There are few benign tumors which can cause fever. One of them is atrial myxoma. Atrial myxoma can present similar to as a chronic infection, recurrent fevers, non-localizing fevers. Okay. And same second is again the same rule, mesenchymal tumors. Large fibroid in the uterus can also present with the inflammatory clues because of ongoing subtle necrosis in in the tumor. Okay. Now, there are some clinical clues which make us think more about the fever. One of them is a non-responsive fever, fever which is not responding to Panadol or non-steroidal anti-inflammatory drugs. Okay, think of, and is a chronic fever. Infection has been excluded, and the fever doesn't respond well to the anti-inflammatory or paracetamol. Okay. Second is recurrent fevers. Fever comes for a few days, then goes away, and then comes back. Okay, as I said, cancer doesn't follow any physiology, cancer doesn't follow any rule. So, intermittent fever or the fever which comes and goes, some days is there, some days is not there. Okay. Third, there are few clues with the non-specific clues, but actually they are very specific. If you ask me, they are very specific. Fever with pruritus. If the patient is having unexplained pruritus, there's no skin problem, patient is not jaundiced, patient is not uremic, patient is febrile and having a lot of itching, generalized itching. Think about malignancy-related fever. Okay, pruritus is a very good clue. Fever with the night sweats. Again, very important clue. It could be a chronic infection, but it could be a malignancy as well because of the slow necrosis of the tumor. And plus, the tumors stimulates production of the tumor necrotic factors. Tumor necrosis factor is the one which causes slow burning of your fat and your muscles. That's how it causes weight loss, and that at the same time it causes slow burning of the body fuels. It produces heat as well. So that causes fever. Okay. So, fever with the night sweats, fever with unexplained generalized pruritus, fever with skin discoloration. Okay, sometimes it can be paraneoplastic skin manifestation of the tumor, which is causing the temperature. Okay, so think of malignancy in these cases. Then, of course, there can be a clues for the underlying malignancy, such as patient has weight loss, patient is cachectic. Okay, that make us think, oh, what's wrong? This could be a malignancy related fever. Okay, of course it can be TB because weight loss is a feature of TB, but weight loss can also happen in the malignancy, right? Now, fever with night sweats, fever with pruritus, and fever with cachexia, fever which is not responding to anti-inflammatory or the paracetamol drugs, they should make us think of malignancy, underlying malignancy. Okay. Similarly, fever when you have excluded the infection and there's no autoimmune disease and there's no other reason, you also think about underlying cancers. Okay. And as I said, malignancy may not be evident right from the beginning. Okay. So it may be a hidden malignancy which is still there and causing temperature, but we are not detecting it. So patient will need a serial imaging, or patient may need a PET scan as well. Okay. Right. So these are the things which with the fever with malignancy. Malignancy also causes cachexia. So fever in a cachectic patient, malignancy comes. Then fever with the other paraneoplastic manifestation. For example, patient started having new findings of limbic encephalitis in the form of psychosis and hallucinations and those things. Patient is not known to have psychosis in the past, but now is having paraneoplastic neuropathy or paraneoplastic myositis or paraneoplastic limbic encephalitis and having fever as well. So this could be a malignancy. Okay. So now, whenever we think about malignancy as a possibility of the fever, we need to keep the patient under surveillance, under regular follow-up, and may need interval imaging again to pick up the malignancy. All right. So that's about few things about the malignancy-related fever. Now, the fever due to autoimmune diseases. Remember, autoimmune diseases, in many cases, will give you some systemic clues, such as skin rash, such as manifestations of vasculitis, such as polyarthralgia or polyarthritis, excuse me, or other organ involvement, such as bilateral interstitial pneumonitis, or skin rash, photosensitivity, alopecia. All those things may be there. But many a time, autoimmune diseases may not give you any other systemic finding, and they just present with the fever. This is quite common with lupus, although not in majority cases, but quite a significant number of cases of lupus and other autoimmune diseases can just present with the fever, and rest of the systemic manifestation they start at a later stage. Okay, maybe after a couple of weeks or a couple of months, and then they uh, become evident. Okay, but in that up till that time, till the time the other manifestations are obvious, it can still be autoimmune fever. Again, the same rule as was discussed in the malignancy. Autoimmune fever is also a diagnosis of partial exclusion, which means we need to make sure this is not an infection. Okay, even in a patient with a diagnosed case of autoimmune disease, patient has known case of SLE, known case of rheumatoid arthritis or a vasculitis or any other autoimmune disease, and now it's coming with fever, infection is still more common than the autoimmune fever. So infection need to be excluded or treated, and if we have excluded the infection, then we think about autoimmune fevers as well. Autoimmune serology can be helpful, but sometimes autoimmune autoimmune serology also fluctuates. So one single negative antibodies doesn't exclude any autoimmune disease. Okay, so we might need to repeat it after an interval of week or 2 weeks or a few weeks. Okay, uh, some of the findings of autoimmune fever without any without any extra any other organ localizing clues for the autoimmunity could be non-specific rise in the inflammatory markers, such as high ESR in the setting of the fever, but it's not TB, it's not lymphoma, and patient hasn't got any physical manifestation of the autoimmune disease. If the ESR is very high, always keep autoimmune diseases higher up in the list if it's not infection. Okay. Another finding is elevated globulins. Elevated globulins without any definite reason. Okay, you should think about, does this patient have autoimmunity as a cause of the fever? Okay, so autoantibodies, cryoglobulins, and globulins or globulins, high ESR, unexplained high CRP, all these clues should make us think that this could be autoimmunity or multi-organ involvement, but at a subtle phase, which is not committing to a definite autoimmune disease. For example, patient coming with the fever, there's transaminitis, okay, but there's no infection. There's all the hepatitis screen has been negative, and patient is just having fever, but no other autoimmunity clinically detectable, and no antibody is positive. It could be a beginning of autoimmune hepatitis. Okay, so autoimmunity is one of the strong possibility if the infection has been excluded and clinically it's not fitting in a malignancy related fever. Okay, next is a drug related fever. Okay, drug related fever, unfortunately, I think I committed with the team that I will finish fever in 2 lectures, so I am trying to squeeze the things. But uh, our drug related fever, the first and foremost important thing is a temporal association of the fever with the drug intake. Fever should start after the drug was started. This is important. This is very important. Fever should start after the drug was started. Right. So if the fever started after a drug was started, it can be a drug fever. Second, when we stop the drug, fever goes away. This is another clue. And when we recommence the drug, fever comes back. This definitely proves this is drug-related fever. It could be a drug allergy. Patient may have other findings of the drug-related fever, such as skin rash or a fixed drug eruption, okay, or eosinophilia, or other side effects of the drugs may be there. Okay, some of the drugs are quite notorious to cause fever. Now, the drugs can cause fever by multiple mechanisms. One is drugs can alter hypothalamic thermostat. Those drugs which acts on the CNS, such as antidepressants, antipsychotics, okay, they can cause temperature by antiepileptics. They can cause temperature by adjusting the thermostat of the hypothalamus. Remember, hypothalamus is made up of neurons, okay, and all the neurons have many things in common. Any drugs which are acting on the other neurons can also act on the hypothalamus. Anti-epileptic, antipsychotics, antidepressants, analgesics. Okay, they all can cause altered hypothalamus and can cause fever. So remember, if the patient is on the drugs which act on the CNS, think about them. They may be the reason. Drugs which causes cell damage, cytotoxic drugs, such as cancer chemotherapeutic drugs, or immunosuppressant drugs, because they causes a lot of tissue damage. So they release a lot of tissue mediators, inflammatory mediators. So they can cause fever. Drugs can cause fever by making heptin molecules. Heptins are basically altered antigen. Okay, drugs can bind with your routine molecules of the body, and they become immunogenic. Because, for example, drug bind with the albumin or drug bind with the cell protein. Now that protein is not normal anymore. Okay, immune system will identify it as a foreign or abnormal protein. The immune system can start reacting with it. And drug can cause fever by through the immune complex formation. So there's a drug molecule, antibodies come, they combine, they make immune complexes, and they can cause uh, immune complex manifestations. Right? I'll give you the time after that at the end of the lecture for the answer questions. I just want to uh, continue finish this drug fever. So most important thing is temporal association with the fever. Okay, other clues for the drug side effects may be there. Okay, and drugs which are notorious to cause fever, they are, any drug can cause fever, but most importantly, antibiotics, anti-cancer drugs, and drugs which acts on the CNS, on the nervous tissue. They are more notorious to cause fever. Okay, but again, the drug fever is a diagnosis of exclusion, diagnosis of complete exclusion, not partial exclusion. Malignancy and autoimmune were diagnosis of partial exclusion, that we exclude the infection and they are in. Malignancy and infection, autoimmune are in. Okay, drug fever is a diagnosis of complete exclusion. We have to make sure this is not a malignancy related fever, this is not an infection related fever, this is not autoimmune fever, and this is not an endocrinal or hypothalamic fever. So that is where the drug fever is. Okay, now if you keep all these things in mind, especially what we miss commonly are the malignancies and autoimmunity. One more thing is there's autoimmune disease, okay, and there are inflammatory conditions which are not completely classified under the autoimmunity, but they are auto-inflammatory conditions such as familial Mediterranean fever, okay, such as TNF receptor related fever. So basically, these are the diseases which are, most of them, they are genetically mediated. Patient has genetic abnormalities, okay, and their body on its own keep stimulating the inflammatory system, neutrophils and innate immune system. These are the disorders of the, not the acquired immune system, but they're disorders of the innate immune system, especially the neutrophils. Okay, so the body uh, on its own, because of the genetic abnormalities, start taking the initiative and releases inflammatory mediators through the inflammasomes, and that causes fever. One of them example is familial Mediterranean fever. Patient has recurrent peritonism, or patient has recurrent pleural effusions and pleuritis, pleurisy, either alone or in combination with the peritonism, and patient come with the fever. Patient can also have the joint pains as well. So usually the body coverings are inflamed. Recurrent inflammation of the pericardium, pleura, peritoneum, synovium. 4 body coverings, not the meninges. Pericardium, pleura, peritoneum, and synovium. These are the common body coverings which are inflamed, which get inflamed in the familial Mediterranean fever. Patient can present with arthritis, peritonitis, pleuritis, and pericarditis and fever. Okay, so these are familial conditions. So patient can have intermittent, intermittent pattern of the fevers, just like malignancies. So the fever comes and goes, and we fail to diagnose any infection or autoimmunity or cancers or drugs responsible. And these are usually late to diagnose because it takes time for us to exclude all those common things first. Infection number is number one whenever you find a patient with the fever. Okay, infection, infection, infection. And to diagnose the infection is you it's better to follow what are the additional clues with the fever. Okay, so to summarize, fever with weight loss, fever with rigors, fever with anorexia, fever with lymphadenopathy. And if it's a lymphadenopathy, see what type of lymphadenopathy is, how many areas are involved, are they of the same size, or one of the lymph node is much bigger than the other, what size are they having, what's the consistency of the lymph nodes, is there any necrosis in the lymph nodes, are these lymph nodes matted with each other, are these lymph nodes fixed with a adjacent structure. So these are the clues which will help you to evaluate the significance of the lymphadenopathy. Okay, fever with splenomegaly, petomegaly, and fever with all these clues which we have discussed today. Okay, so that's where I think will stop this, and now I will give you the time for answer questions. Please feel free to ask questions. There were a few questions sent to me in writing, which I couldn't read properly because uh, I thought I would give you the time at the end of the lecture.
There is a
Sir,
question from,
thanks.
yes, Salman, please ask. Yes, please.
So my question was how to be sure कि ये
Can you speak a bit loud? I can't hear that.
sir how to be sure कि ये infective etiology है lung में, not the adenocarcinoma जबकि TLC count भी normal हो. How to differentiate viral and fungal infections from underlying malignancies?
Viral and fungal infections from underlying malignancy in a patient with a lung cancer. Is that a question?
Yes, sir. Yes, sir.
Okay. So look, lung malignancies per se, they are not common malignancy to present with the fever per se. Okay. Because the solid malignancies which present with the fever, they're mostly the mesenchymal tumor, but not the lung tumor. But they can present. Usually, the lung malignancy will cause fever if there's a necrosis in the lung malignancy or the malignancy is metastatic. So, this will be the background usually. Viral infections are usually acute onset, and the history will be short for few days. And remember, viral infections, they viral secretions are water-like. Anything which is not water-like is not viral. Okay. For example, there's a phlegm with the blood in it. Forget about the virus. Think about bacteria and something else. Okay. And viral infection, they virus has a common pattern that it irritates all the passage which it passed through. For example, it causes viral prodrome, flu-like symptoms, runny nose, sneezing, cough, and those things, and then it settles in the lungs if it at all it settles. Okay. Then viral infection, if it involves the lungs, it usually causes bilateral interstitial pneumonitis pattern rather than focal consolidation, unless the patient is severely immunocompromised or the viral load is too high. So viral infections, usually they're acute with a viral prodrome, and the secretions are purely water-like. They're not green, they're not yellow, they're not blood containing. Okay. The fungal infection, yes, fungal infection will happen if the patient is having metastatic cancer and the patient is on cancer chemotherapy, especially when the patient is neutropenic. Okay, so they will be at more likely to have a fungal infection. But fungal infections, even if the patient is immunocompromised, because they're they're chronic infections, so they're slow to start. They will take at least 1 or 2 weeks to start, unlike viral infection, which will be gone by 7 days, after a few days, right? Okay. Fungal infections, number one, they're slow to onset, they're slow to start. Okay. Number two, fungal infection, if it's aspergillosis, it will usually cause the upper lobe infection more than the low lobes. And rest of the fungal infection, they usually go in the low lobes more. And that location may be different from the actual location of the tumor itself. Okay. So location of the infection will also give you a clue that is it at the same location where the cancer is sitting, or is it a different location? You got my point? And the reason the fungal
Yes, sir.
infections are,
Right, sir.
pardon?
Yes, sir. Very right, sir.
Yeah. And another thing is, if a patient of the malignancy, lung cancer, is coming with the fever, and we have given the antibiotic for 5-6 days, patient is neutropenic, patient has a malignancy, patient is on chemotherapy, patient is neutropenic, we have given the antibiotic for a week or so, and patient is still spiking temperature. This is the indication that when we start antifungal treatment, regardless of isolation of any fungus or not, we try our best to find a fungus in the specimens, in the sputum or other things. But even if we fail it and the patient fulfill this background, patient is on chemotherapy, patient is neutropenic, and the fever is going on for more than 5 days and is not responding to antibiotic, this is one clinical indication with which, regardless of the detection of a fungus, we think about and we add fungal treatment. Does it make sense?
Yes, sir. Yes, sir.
Yeah. And one more thing I would explain is the fungal infections are more common in neutropenic patient because of the fact that neutrophils, they produce hypochlorous acid. So what happens is this oxygen free radical, it binds with free hydrogen and make H2O2. That combined with chloride and make it HOCl, hypochlorous acid. Hypochloric acid is the main weapon of the neutrophils. Okay. This H2O2, if you add catalase to H2O2, it will break into water and oxygen. Okay. So catalase producing organisms, they paralyze the neutrophils by breaking the H2O2 into water and oxygen. So neutrophil can't make HOCl now. They can't produce HOCl. So that's why the patient who are neutropenic, they are high risk for fungal infection. So any patient who is neutropenic and is not responding to treatment for 5-6 days, always think of adding the antifungal treatment.
Right, sir.
Any other questions? Those of you who have sent me a written question, please ask it, because now I'm.
Yes, sir. Professor Tajammal Chaudhary Saab is a retired professor of forensic medicine. Sir, please unmute your mic and please ask.
Thank you so much, sir. Truly honored to talk to you and listen your awesome comments. Sir, I'm a toxicologist, and how does aspirin toxicity increases the temperature of the body, though it is also given to treat the hyperpyrexia?
Yeah. So aspirin is basically salicylic acid. Okay. One of
Please,
its
sir. Yes,
mechanism.
sir. Please, sir. I'm with you, sir. I'm with you.
Yeah. One of the mechanism aspirin causes is a mitochondrial toxicity. So basically, it causes the salicylic acid in a very high dose. It causes uncoupling of the oxidative phosphorylating pathways. So in the mitochondria, the pathways running is oxygen, and we are running the electron from one complex to the other complex to the other complex, and we generate a electrochemical gradient, just like we do in a mangla or in a water dams. We take the water at a higher position to generate energy, to create a potential energy, and then we let it fall, and that gives us the we convert that energy into the electricity. Same things happen in the mitochondria. we run the free electron from, there are four complexes, from first complex to the second, second to the third, and third to the fourth. And with every jump, the electrons gains potential energy. At the last jump, they come inward. We use that energy of the electron which they have gained from previous complexes, and we use that energy and make ATP. This is called as oxidative phosphorylation. Okay, that we're moving the oxygen and electron,
Boss. Great.
and we're making ATP. Aspirin and many other toxins, they causes uncoupling of this pathway. So now these two pathways are not linked anymore. So the energy which was
Perfect.
gained by the electron will be wasted as a heat. So aspirin basically causes hyperthermia. It doesn't cause fever, it causes hyperthermia by
Very right.
uncoupling.
Very right, sir. Very right. Very right.
Thank you, sir.
And how does it improve the temperature?
Because it blocks the prostaglandin synthesis in the hypothalamus. This is how it works as antipyretic. But at a very high dose, in a poisoning dose, that this mitochondrial toxicity mechanism dominates everything else.
Right. There was one question from Dr. Kainat Batul. Kainat
Yeah.
Batul, can you please open your mic?
Hello, sir. Am I audible?
But can you speak a bit loud?
Am I audible, sir?
Yes, now you are audible. Yep.
Okay. Sir, I'm a little confused regarding sinus formation. You said that TB usually respects tissue planes. So why does it then form discharging sinuses?
Yeah, discharging sinuses are basically because of the fact. The first thing is, when the TB spread from the one lymph node to the next lymph node, there's a difference between spread from one lymph node to the next. Cancer cells, they spread through the lymphatic channels. Infection, they will break the capsule and spread from one lymph node to the other lymph node. This is how the lymph node become matted. The same mechanism is, the lymph nodes first they become matted with each other or with the overlying structure, and then with the passage of the necrosis, the part of the lymph nodes which is there between the center and the skin ultimately get necrosed, and then there's no lymph node left, and that part is empty now, and now the infection is in direct contact with the skin. Ultimately that skin will also break off, and that will make a sinus. Okay, and lymph nodes are very superficial, but this rule in the lungs, nocardia doesn't follow the tissue planes in the lungs. That was about the lungs, not about the lymph node.
Okay, sir, right. Thank you very much.
Yeah. So what I said about the nocardia was in the lungs. Any other question? Sorry, I couldn't hear you.
No, there's just an interruption.
Okay.
Okay, I think we're done with this lecture. Dr. Asif, thank you so much. And although the participation was a bit low today, but there was problem with my internet connectivity, probably because due to heavy rain at Lahore, there are some electricity issues in Lahore today, and the voice, the actually bandwidth of my internet speed was a bit low, so there was quite frequent interruptions in the voice, but we requested you and you repeated it. I think the message is well conveyed, and I think we can have a third lecture also if there is, along with the discussions of the participants, if they want to. I will issue a poll on the WhatsApp group, and if all agree that we should have third lecture, then we'll have an additional lecture on fever with discussion of the cases by the participants. But if there
Yeah, that's
is
fine.
no the candidates feel and the residents feel that we're done with that, then we'll move to the next lecture. So
Yeah, that's all good with me.
the next topic would probably be
Maybe uh, diarrhea or lymphadenopathy.
okay. I think we can have lymphadenopathy. We will also discuss fever with lymphadenopathy in continuation of that lymphadenopathy.
Yeah, that's fine. We can do that.
Okay.
You
Okay.
can choose any
Correct.
topic. I don't mind whichever topic the candidates want. I'm more than happy to cover it.
Okay. Okay. Thank you.
We
I
can
know.
keep going with the fever if they want. We can have multiple lectures, but it all depends what is their need.
Okay. Right. Yes. चलें. Thank you, Asif bhai. बहुत शुक्रिया.
Thank you.
We'll conclude it today. And thank you very much for the participants for their participation and listening. I hope next lecture will be more inclusive and participants will be active in the participation. Thank you very much.
Thank you, ji. Thank you, ji.